Well, hello again to everyone, and Dr. Power, welcome back. Thank you so much for taking this time to answer some of the questions that we were not able to answer during the session. We ran out of time. It was a great and rich discussion, but we had some questions left that we would be very grateful if you can answer for us. So the
Be
first
happy to do that.
question, thank you. Thank you, Dr. Power. The first question is asking if there is a community of practice for this.
At the moment, there isn't one that exists. I think the closest thing we've had to that is, as I mentioned in the presentation, my colleague who's doing this across several different homes across the state of Arkansas. They do not work together as a community of practice. There are communities of practice popping up in Ontario now because of recent legislation that's going through about having a dementia program. And I can say that there is a course that the RIA, where I work in Waterloo, has developed a basic course called Living the Dementia Journey, which is being used as a community practice by the region of Halton. So some people are doing this around certain educational products. And we have had some talks with some of the Hamilton region homes about setting up community practice too. So there are those discussions going on. But I would always be happy to talk to people about using this as a foundation for community practice.
That's wonderful. So, Dr. Power, if anybody wants to get access to those communities of practice, would you recommend that they reach out to RIA at this point? I know that in Hamilton, Greater Hamilton Health Network, long-term care administrator and DOC group is working on this in collaboration with Thrive Group Center of Excellence. So, if anybody in the Hamilton area or Greater Hamilton Health Network area wants to stay up to date with the communities of practice plans, they can reach out to either myself or Holly Odwardi. But would you say that RIA would be another place for others that they can reach out to?
Yeah, if they would like to look at that resource, the resource called Living the Dementia Journey, it's an excellent course. It came from a course that was developed at Schlegel Villages about a decade ago. And I was a consultant on that course, and it's very congruent with a lot of my philosophy. So it's a good basic one. Or they can reach out to me as well if they have other questions. I can steer them, hopefully.
Wonderful. Thank you for that. So we'll go to the next question. Do you have any recommendations or resources for healthcare providers looking to find ways to advocate within their organizations to get support from leadership and increase buy-in for these person-centered approaches? Uh, and there's a follow-up question to that. What's the
Mhm.
one thing you wish you could track continuously and automatically to improve care for people with dementia? But I'll break it down for you. So first, maybe we'll
Okay.
ask you to share the recommendations or resources.
Okay. Yeah, the first one takes a few words. The second one I is easy. I got an easy one for that. But for the first one, yeah, we're really talking about a culture change. It's more than just education. It is changing systems. It's changing the culture of how we see dementia, how we support people living with dementia, and it absolutely requires that leaders, formal leaders, embrace and drive the change. Even though we talk about empowering staff, if the formal leaders are not there behind their backs supporting the licensed staff or worries about putting their license on the line, if they're not saying, listen, we believe in this, we support you, then it's not going to go anywhere. So most good culture change processes start with formal leadership coming together and looking at their core values, what they believe, um, and that's really important to drive it from values. A lot of people just look at initiative and they say, okay, how do we do this instead of why do we do this? And the why is really important. And really committing to this. What's the kind of place, not only where we want to create for our residents to live, but what's the kind of place where we would want to live? Because we're talking about our own futures too when we talk about long-term care for many of us. And I will say, I worked with amazing people, around the world and across the US and Canada, but it was many, many years in the culture change world before I walked into a place where I said, okay, maybe I could live here. And it's a real challenge. As much as we love our coworkers and our organizations, it's a real challenge for many of us to say, okay, I love this place, I love my job, but if I had more needs, would I really want to live here? And a lot of people can't say they would. And if not, then there's a gap, and people have to move in that gap. Now, they're organizational change consultants. Some of them work with large culture change organizations like the Eden Alternative or like the Pioneer Network, or there's culture change training from the RIA, for example. Some people work independently and do it their own way. But I do recommend that if people don't know where to start, if leadership doesn't really know how to go about this, that they look into maybe getting an organizational consultant to sort of help steer them in the right direction. But it really starts with conversations, because they know best who they are and what they want. And an outsider can give you suggestions, but they need to really drive that from their own values and their own culture. So that's the long answer to the first part. Second part is simple. I would like a good way to track those 7 well-being domains for each person over time, and to show that we are filling those glasses and helping people to experience better well-being in all those categories. The difficult part is that we don't have, in my mind, a good well-being tool, a good scale for measuring that. Most of them are still based on medical outcomes, functional outcomes, but not really. And quality of life sometimes is tied into those rather than these well-being domains. The good news, I hope, is that I'm going to be working with a couple of the researchers at RIA, Dr. Karimi and Dr. Laura Middleton, and maybe others. Phyllis Fair indicated some interest in being part of this, and that is to possibly develop a new tool, a new scale for measuring well-being domains, and quite possibly those 7 well-being domains. We'll see. There is a scale I helped develop for the Eden well-being domains when they came out about 15 years ago. For many reasons, I'd like to see that one updated. I think we can do something better, and one that might be able to capture more responses from the actual people living with more significant cognitive change. That's what I would do.
Love the answers. And Dr. Power, I just want to mention something that you brought up, that if we want to know if we're doing a good job, the question is, would we want to live in that space that we provide care to our residents and clients? That's a really good test. And that is something that I have always thought about myself, within the organizations that I have worked at, the homes. And there have been several that I would, including our current homes at Thrive Group, I would want to live with them even right now. So
Yeah.
that's a really good one. So for me to actually encourage others to reflect on as well. Thanks for sharing that. Okay, so let's go to the next question.
Okay.
Considering culture impacts perceptions of health and approaches to care, how can we provide support while maintaining cultural sensitivity across diverse communities?
Yeah, I think that's really important, and it's going to be more important as time goes on. I read not long ago that if we just look at people living with dementia in Canada, currently about 8% of those people are from Asian background, for example. But by 2050, that will be 25%. So Canada is already a diverse country that's becoming much more diverse, needless to say. And so I think that's really important. There are a couple of things that the RIA has done. My colleagues, same colleagues, Dr. McKinney and Dr. Middleton, they have a Forward with Dementia initiative, which kind of has some cross-cultural information. They also have a new guidelines on inclusive research principles, which I think are really great, to help include people of different backgrounds and include the people with dementia in research protocols. But a lot of it, when you look at the well-being domains, it's all about the individual. Identity is partly your cultural background, your history, connectedness. What are your important connections? Meaning, what are your rituals? What are the things that mean to you? And even when you get into things like autonomy and security, different cultures have different ideas about decision making. Are we more collectivists, more community oriented in our decisions? Are we more individualist in our decisions? Do we defer to our elders? Do we respect them in certain ways? Do we not? so really around what makes you feel safe, what makes you feel in control, they're very different cultural backgrounds. And so I think that the well-being domain really demands that we look at that individual and we see that whole individual, and that culture is a big part of it. I imagine that you probably have a lot of background in this area too, from what I've seen you do in your work, and I certainly welcome other thoughts from you about what you've done in this regard too.
Thank you, Dr. Power. Yes, absolutely. In many long-term care homes, we are providing care and services to very diverse communities. So maintaining cultural sensitivity becomes foundational to everything that we do. It's not just an add-on. It becomes a foundation. And I think something that collectively we try to do, and I'm sure we can do better, is listening first and acting second. So, what you mentioned regarding how to really utilize these communities themselves to understand what they need, because one size doesn't fit all. And those models are not successful when we're thinking about cultural sensitivity. And really, as you mentioned, health and well-being are really deeply personal. And they are shaped by cultural beliefs. So when we're thinking about right now, Ottawa Manor has been identified to provide French language services, for example. But it's really beyond just translating materials to a different language. It's also translating values, and that means involving communities such as the French community right now in the co-design and integrating those traditional healing practices wherever they're appropriate, and really respecting those familial decision-making structures. So that is something that is really embedded within many leadership structures that they fully understand the foundational role of cultural sensitivity to what they do.
Thanks. I love that. I love the involvement community in co-design and just the concept of listening. I do. I think that's incredibly important.
Thank you. Thank you, Dr. Power. The next question is asking, I am wondering strategies when someone is fixated on leaving an area in the hospital and is exposing themselves to an unsafe situation. For example, we had a client who would not understand why she needed someone to go with her to cross the busy road outside of the hospital. She could not recognize when to cross the road. Staff and family would go out with her almost daily, but sometimes she would decline and try to go out by herself, putting herself at risk. So it was felt pharmacological and non-pharm interventions were required for her safety.
Mm-hmm. Yeah, that's obviously a very challenging scenario on this being presented, and I think sometimes we tend to generically look at things like, things that we label as wandering or trying to exit the living area as being generic. But once again, just as we talked about the cultural sensitivity, every person does what they do for very individualized reasons. So in my consulting and being posed challenging scenarios like this, there's nothing I can do as an outsider that necessarily answers the question, because I don't know the person, the situation, and it will be different. There's no general rule for what to do when somebody wants to go outside. But there are a few things I can say about it, I think. And the first thing I can say is that when I think of all the things that might motivate someone to feel they need to go outside or need to cross the road or need to be somewhere else, I can't think of one where giving a sedating medication is going to help the situation. Generally, that will make it more dangerous, because it's not going to take away the reason why the person wants to do what they want to do. All it will do is provide some sedation, which means that when they get up, they're more likely to have unsteady gait, imbalance, and falls. And I know in my experience, as hard as it is to keep somebody from leaving who wants to leave, it's even harder to keep somebody from walking who has just fallen and has a hip fracture and still wants to leave because you haven't solved that problem in the first place. And these drugs, even though people don't always look like they're falling asleep, these drugs have profound effects on the nervous system. And when I was in my training, the term that we used for antipsychotics was the major tranquilizer drugs, and that's what they are. They are major tranquilizers. So really, that is not a solution, and it not only doesn't provide a solution and creates risk, but the third problem with it is that when we have the pill, then we stop thinking critically about what's going on here and how can we find other ways to solve it, because we have this task we can do to kind of push things down the road and actually create more danger. So there are a lot of things. My well-being approach would say it may not just be one thing. I mean, you certainly want to talk to the person. You want to find out what they're trying to accomplish. You want to find out what it means to them, where they're going, what they need. But the problem with just seeing things as unmet needs is we just think it's one thing, like, I have to go to the bank and get some money and that will solve it if I give her some money. But it's usually much more complex. There are usually many areas of well-being which are being eroded. And when you're in the hospital, of course, you're stressed even further with that acute situation. So, what is it about the person's sense of autonomy, for example? Maybe they're trying to leave not because they have a specific place to go, but because they don't have any choice or control. And I've seen a lot of people try to escape a situation where they're driven in the crisis because they feel like everything is so much out of their control. They just have to bolt. They have to escape. They have to do something to exert some authority over a situation they can't control. It may be something about security. There may be things we're doing in the hospital that we think are good for the person that are making them feel unsafe. And so they have to get outside. They need to get away. There may be something about, connectedness. Maybe there's something, that's missing. There's some connection that they're needing, whether it be family, whether it be community, whether it be some other aspect, just getting in fresh air or just having to move because they always move. And we can take people outside, but once again, unless we look more deeply, we may miss that. And once again, with something like autonomy, sometimes it's not actually where they want to go across the street. It's giving little choice and control in every interaction, so that they feel more in control of their life and they feel less likely to need to escape the situation they're in. So that's where the well-being approach is different. It looks proactively. It doesn't just say what do we do when. It says what do we do all day to prevent these lack of well-being. And it says it's more than one simple thing where we can just have an intervention. It really is about creating a plan that gives the person what they need to feel safe, to feel in control, to feel like they can manage the situation they're in. And I guess the last thing I would say is, because and you and the Thrive Group are experts in medically complex care outside of hospitals, and when you have a situation that's very extreme like this, if there is a way that you can provide that medical care in another setting that is more familiar, whether it be long-term care, whether it be their home, if you can set up home IV therapy, if you can set up, outpatient appointments for whatever treatments are being given, anything you can do to get the person out of that hospital environment and provide the care. When you're able to do that, then do it as quickly as possible. Because a person that can walk across the street might not need to be in the hospital. They might. I don't know what the situation was, but let's be creative. If that person is that mobile, do they need to be in that bed, or can they have this service provided with extra? It's in the long run, it's cheaper to send an IV team or another hospital-based team to provide treatment in the person's own setting than it is to have to put up with the risk of having that person in the hospital and forcing the treatment on them in a very scary surrounding.
Thanks so much, Dr. Power. So I have a follow-up question on that. So
Yeah, please.
we know that the prescribers obviously are the ones that they prescribe the medication, but when we're in care teams, many times we observe that medication is prescribed by the prescriber because the rest of the team is bringing an issue with a recommendation and a request for medication. So really, it's not just the prescriber mindset that needs to shift and look at these situations with a well-being focus first. And yes, we know that medication sometimes must be necessarily, but in many situations, it seems like we might not need medication. So the shift in the mindset of the rest of the care team, who are not necessarily the prescribers, is as important as the prescriber's mindset, I assume.
It's a critical and central point. I'm glad you brought that up. You know, when I wrote my first book, and I'd never written a book before, and I read books about how to write a nonfiction, scientific or academic type book. One of the first things that one of the books said is you need to decide on a core audience for your book. And it was funny because I was reading that and I stopped reading and I said to myself, well, I'd love everyone to read my book. And I went back and I swear the next thing that was written was, I know you want everyone to read your book, but you still have to come up with a core audience because your language, your examples, the things you talk about still have to be directed at the core group of readers. And I decided then and there that the core group I was writing to was not physicians. The core group was nurses and other healthcare professionals who are doing the hands-on support, because that's true. They are the ones who pick up the phone and tell the doctor we need something. And as I often say, doctors don't know how to do day-to-day care. They know how to prescribe pills. So if you call a doctor, you're basically asking for a pill. You don't call me because you want me to give you a lecture on how to shower somebody. That's not something I learned in my training. Um, and uh, and I have rarely seen doctors walk into either a hospital ward or a neighborhood of a long-term care home and say, "Okay, who can I give an antipsychotic to today?" That's not their mindset. The mindset is, I'm responding to a concern that's been brought to my attention. And so my feeling was, if my training could give those people who provide the primary care the tools to find other solutions to keep them from picking up the phone, then that's the key. And I tour places that use no antipsychotics, and a couple of times I've asked the nurse manager, "How do you get the doctors on board?" And they say they follow our lead. If we don't call them up saying we need something, they respect us and they don't force pills on us. It's only when we say we can't manage this that they're going to come up with a medication. So yes, doctors need to know this, but really the driving force, I always say that it is actually a nurse who decides whether antipsychotic needs to be prescribed, not a doctor, because that's where the phone call happens.
Very powerful. Thank you, Dr. Power.
Thank
Let's
you.
go to our next question. Fantastic talk. Thank you so much. I'm a clinical nurses
Thank you.
specialist in a
Great.
health program in Hamilton. How
Super.
do we change the hospital systems? Where do we start to focus on well-being for dementia? What first steps do you recommend to take to change the system? Great
Well, that
question.
sounds easy. Great question. Great question. Easier said than done. I know. It can seem impossible. I mean, I know the struggles of changing a long-term care system, and I think with hospitals, even more competing priorities that make this really difficult. There's two aspects to it. Number one is education, and I do say the right kind of education, because I think we do give education about dementia, about older people, about delirium. But once again, is that education steering people toward different solutions? If the education is about BPSDs and the need for antipsychotics because of dementia-related behaviors, which, as you know, I challenged a lot during the last hour, or if it's about problem behaviors, if it's about managing people with dementia, then it's not giving the right message to help people think differently and find new solutions. The well-being training I do spends a lot of time reframing how we look at dementia, how we look at the way people, what people do, what they say, and see it as more than just the symptoms of dementia. So that the right kind of education is really important. So it means learning, but it also means unlearning some things we've been taught in the past too. Then the other big part, and the part that's really much harder than that, is the system change. So once again, if I were, if I ran the show and were invited into a hospital and given carte blanche to do it, I would just talk to a lot of people. I would not only talk to the people who provide clinical care about their experiences, I would talk to people who are in the hospital or who had been in the hospital. I would talk to people with dementia who'd just been through a hospitalization, their family members, hear about their experiences, what worked for them, what didn't. And I would talk to everybody else too. I would talk to the people in housekeeping, ask them what their day looks like, what they're asked to do, and how they do it. I would talk to people in the laundry, talk to people in phlebotomy or in clinical labs, talk to the admissions people about what happens when someone goes to the emergency room. How do they get there? You need to really do sort of a time and motion analysis of all these different groups to find out what the system is telling people to do, and then hear from the people who experience the system what is causing problems for them when they try to survive a hospitalization. And because it's really what needs to happen is the system needs to shift to meet the needs of the person. That's what person-centered means. And we all throw that term around, but most of what we do is not particularly person-centered. We say it is, but we're actually doing things at our convenience. And so that means the hospital needs to make some major systemic change around people who are living with dementia so that their life is not disrupted any more than absolutely necessary while they're being treated for what could be an acute or even life-threatening illness. Not easy, and particularly not easy in hospital because they have bigger priorities. This is not where their money comes from. Let's be frank. Hospitals don't make their money from a person with dementia who has a bladder infection or a hip fracture. They make their money from bypass surgery and in the case of big university hospitals, organ transplants and things like that. And so this is not high on the priorities, taking care of a 90-year-old with dementia. And to change the system for people like that is not something that at least the hospitals I've talked to have been willing to engage with me in. And but the truth is that more and more the proportion of people who are coming into hospitals, who are staying in those hospital beds, are going to be those people. And it is going to continue to create problems with the system. And if you want to see the downstream effect of not doing a better job with people with dementia, look at the ALC population who are taking up acute beds because they have been so traumatized by inattention to these things that they are now in a position where nobody from long-term care wants to take them because they have had so much disruption and so much medication and restraint that they look like the kind of person that no one wants to take. And so now the hospital beds are being occupied by people that they didn't take the time and spend the money to provide better care for in the first place. So if they think that this is not a big part of their budget, I think they're missing the boat.
Thank you, Dr. Power. So for this participant who asked this question as a clinical nurse specialist,
Yeah.
what can this person do specifically in their role that they have? Is there anything that so it seems like they're inspired, they agree with your approach, they want to do something. What would you say that
Yeah.
they can do as their first step?
I would say to get more education along these lines. Go take a course along these lines and begin to advocate to bring that course. And even before they can do that, if they could just show it more and more, just model it in their practice. So some of the things we talked about around well-being, if when they're presented with a situation where someone wants them to, get an antipsychotic, if they could bring something to concept, maybe this is what's going on. Have we looked at this person? Do they feel safe in this situation? Do they feel like they're in control? Are there things we can do in our approach? Are there better communication techniques? And take some of the things they learn and just model them for people around them. I found some of the most powerful lessons I had working in long-term care when people would present me with a challenge that they were frustrated with was to just, when I go to see the person, I would just invite the nurse or the aide to come with me and say, come with me and just, be a fly on the wall and watch what I do and see if there's something different that maybe that you can apply in situations. So I think teaching by doing and modeling for others is an important thing. And then they can also use some of the arguments I just used to try to advocate for the hospital to create a better system of care around this special population so that they are not just shuffled around because somebody needs a bed or not just sent from one place to another without adequate explanation of what's going on, or they're not being woken up for blood pressure checks every 2 hours when they don't need blood pressure checks every 2 hours, and all the things we do to people without thinking, that we just are more aware, just to increase that awareness by reminding people, did you really need to do that at 3 a.m.? Is there a way we can let that person sleep so they're not so frazzled at 8 a.m. when you need them to be alert and able to do things with you?
I love that. So basically, before going out and changing the world, we need to see that shift in our own mindset. So as
Who was it
much
said?
as, go ahead.
Yeah, some ancient Greek said, "Let he who would move the world first move himself," and it's been ascribed to a couple different people. Or Gandhi said, "We must become the change we want to see." A lot of people have said that in different
Yes.
ways, and
Yes.
and Barack Obama quoted somebody else, I think, when he said, "A change will not occur if we wait for the right people in the right time. We are the change. We are the people we are waiting for," or something like that. I mean, yeah, we have to start with ourselves. And my friend Nancy Fox, who does organizational change, was a former director of the Eden Alternative, said, "You can't change other people. There's only one person you can change. You can change yourself, and then you can try to model that for others and invite them to join."
Wonderful. Thank you, Dr. Power. Okay, so the next question is asking, how do we get individuals to open their minds to opening the doors to long-term care homes and locked facilities? And I'm going to read the next question as well because
Okay.
these can go together. I think we are so concerned with safety and acute care, for example, fall risk, that we default to reducing a patient's autonomy in the interest of what we think is promoting safety. How do we change this culture?
That's great. And these are great questions to end with because they're kind of the next chapter after the well-being talk. Because the latest work I'm doing is I've been talking for a long time, as people know if they've read my first two books, about is it really good to have locked and separated living areas for people with dementia in long-term care or in retirement for that matter as well. And I've made arguments about that in the past, but what I'm doing next is I'm co-authoring a book now that actually goes into that in detail. And I'm working on that with Professor Jennifer Carson, who got her PhD at the University of Waterloo and is now in Nevada, and Reno, Nevada, as the head of the Dementia Engagement Education Research Program out there, a gerontologist, and with Patricia Sprigg, who was the CEO of a beautiful multi-level community in Chapel Hill, North Carolina, many acres with woods and a pond and no locked doors, no separation, no gates of any kind. And so we're talking about the philosophy behind inclusion, creating inclusive environments, and also what we call 5 positive pathways to inclusion. And so that's going to be the next thing. But as far as how we convince people to open the doors, the first thing we need to do is just like with antipsychotics. The first thing I did in my first book was I challenged the notion that they were actually working, that they were good for people with dementia, because there was a lot of research out there that suggested that. And when I went back and I kind of dissected that research, I showed that people didn't, they were not studies that were very good at proving what they said was the case. I found a lot of flaws in the studies that I explained. And I think there are flaws in the idea that a locked door keeps people secure. And so by presenting real life arguments about whether what we're doing is best practice, I think that's a good place to start changing people's minds, because people look for evidence. And it's just assumed that when you lock a door, people are safer. One thing we talk about and that we will present is a landmark study done in the US at one home about 30 years ago, where they just observed people with the doors locked and with the doors unlocked, 60 hours each over the course of several weeks, and didn't have any other intervention, any other change in care. And when they just look at what they call distressed behaviors, some were verbal, some were physical, what they found was when the door was locked, the number over that period of observation was over 1,500. When the doors were unlocked, that went down to just over 400. So what they found, and this was not just at the door, this was elsewhere, in personal care, for example. So what they found was that having a locked door, a confined space, in and of itself was a primary cause of the majority of distress that was happening on that neighborhood. And so when you think about the fact that we are giving people antipsychotics for their distress, if you think about a locked, segregated unit, if maybe, as many as 75% of people who are getting these dangerous drugs are getting them primarily because the door is locked, have we made them safer? We know that if you're on antipsychotic with dementia for more than 3 months, about 1 in 36 people will die directly due to that pill. The UK Department of Health estimated at one point if you're on those drugs for 1 to 2 years, the death rate could be as high as 1 in 6 or 1 in 7 due to the drugs. So, is this really safe? And then the other side of this is, okay, yeah, well, it could be dangerous to go out unattended. But when they did unlock the doors, what happened? Nobody went for the highway. What happened was people looked outside. They might step outside, hold the door, look around, satisfy themselves, and come back in. So there might be the occasional person that might try to cross the highway, but the vast majority just did not want to feel like they were in jail, like they were confined. And you can care plan around the exception who might need more attention when they're outside the door. But the vast majority of people just want to feel like they have some freedom. And, the green care farms in the Netherlands have proved this many times over. They are not locked or gated places. And one of the people that runs the green care farm has a great saying. She said, when people are free to go, they choose to stay. And that's a really powerful thing. We have a mindset, getting to the second question, surplus safe. The idea that we are more concerned with the risk, the downside risk of something than the benefits. And we are very unbalanced about that. And we don't realize that when we try to decrease the downside more, we often eliminate any upside for people. And that's why people who are in a locked place do not feel safe, do not feel happy, do not feel fulfilled, because we've taken away any chance for quality of life by confining them against their will. And so once again, you don't eliminate risk, you can only negotiate it. And the risk chapter, which I wrote the draft up for the book, is huge. I can't possibly address it all today, but once again, putting evidence forward to show that what we consider risk is not risk. If the media wrote up every death due to antipsychotics the way they do a death from somebody who maybe gets outside in the wintertime and falls down, or if the state came and investigated every death in a person who was on an antipsychotic, or every death in a person who just gave up because they felt like they were in jail, they were a prisoner and could not get out, I think we would understand that there's much more to this than just, well, what's that one case that could happen that's going to put us on the front page of the newspaper? Well, we're on the front page of the newspaper every day. The newspaper is not writing about, but people are dying from our overtreatment and from our surplus safety every day. But that's not our mindset. And some of it's cultural. I don't know if Canadians and Americans will ever view being able to accept risks in people with dementia the way they do, for instance, in the Netherlands. But I think we need to have those discussions. I just want to share a couple of quotes, and I saw the questions ahead, so I did pull these up from a talk I give on this process. And there have been studies, by the way, and this is the sad thing, in the US and in Canada and in Australia as well, that show that when a person's human rights and our concerns for their safety come into conflict, we almost always take away their rights because of our own concerns. And there's an article that was written back in 2021 by Megan Graham, a researcher in Ottawa. And I'll just read one statement from her paper. She said that it appears that security is prioritized above residents' agency, dignity, and sense of self. And Shoshona Dreyfus and others from Australia in 2018 wrote about a place that had a fence around the property. Now, we're not talking about a locked door. We're talking about people can move around, but they can't get off the property because of a fence. And this was also causing significant distress. And just one quote that I think was very powerful was they said, thus, the fence could be viewed as a symbol of other people's peace of mind and emotional safety, while simultaneously being a symbol of the deprivation of emotional safety for the person with dementia. And they asked, whose emotional safety are we looking out for in fencing aged care facilities? So are we really we're doing what's best for people with dementia, or are we trying to make ourselves feel better about the situation? And once again, it's a big thing to unlock a door. It's a big thing to desegregate memory care. We're hoping our book will provide these 5 pathways and provide a very practical pathway that organizations can follow. And we believe that if you follow those pathways, then when the door is unlocked, you have eliminated almost all the risk just by doing the things filling people's well-being cups, giving them the things they need, treating them in a way that doesn't make them want to escape a place. And then it's just a simple matter of creating some parameters around how do people exit as safely as possible, how to create safe grounds, how do we have a system where we can monitor if somebody needs help, is in trouble. But that's just the icing on the cake. Once you do the basic mindset work, that becomes much, much easier. So stay tuned. Probably next year, hopefully by this time next year, the book will be out and available for people.
That's wonderful. Thank you, Dr. Powers. So we have gone through all of the questions that we had from the session. Thank you again for inspiring us to really think differently and reminding us that dignity is not a luxury, it's a right. And thank you for your leadership, your voice, your unwavering commitment to reimagining care as a space of freedom, respect, and belonging. It is obvious that we need a real transformation when it comes to supporting people living with dementia. And we need to really put all of our hearts and hands and our minds together in order to be able to see that transformation happening within our lifetime. Thank you, Dr. Power.
Thank you so much. It's always a pleasure and a privilege to work with you, Bahar, and it's been a pleasure to work with JRS and the Regional Geriatric Program in this initiative. So I'm glad to be here.
We're grateful to you. Thank you.